and none of the lymph nodes were positive. So would you advise the patient for any adjuvant therapy, and if so, why? Professor Shah, what do you think?
I would tell the patient he's got a good and a bad pathology report. Good because it has not spread to lymph nodes in the neck, and therefore the risk of nodal recurrence is low. But bad because it's a cancer in the wrong place. By any criteria, his biological margins are all positive. Histologically, they may not have seen tumor, but your margins are in fractions of a millimeter from the cartilage, in fraction of a millimeter from the bone, and you have perineural invasion. So he is at high risk of local failure.
So what would you advise?
He will get postoperative radiation, and with contemporary techniques of IMRT, you can spare the temporal lobe, irradiate the bone. Yes, probably the skin graft might slough out in part. Yes, you may get bone exposure, but those are small morbidities in relation to recurrent cancer, which will lead to a miserable death with CSF leak and meningitis.
Panel agree?
Totally.
Okay. The patient did have a perineural involvement, and because of the perineural involvement, which in my own personal experience is a positive margin, we selected to treat the patient, as you suggest, with radiation therapy. And that's exactly what he had. Now, he did very well for about 6 months, and then he came up with a partial facial nerve precis with some residual function of the facial muscles. There was no evidence of any type of local recurrence. Now, what would you do? We were wringing our hands frantically about this perineural involvement coming back and involving the facial nerve. So what would you advise in terms of further evaluation for this patient?
This is on the same side, correct?
Same side.
I think he needs a good quality MRI.
Yeah, and here we are meeting the limits of MRIs. Yeah.
So here it shows enhancement of the facial nerve. So what to do? Temporal bone resection now, or what?
I think with all these things, you need MRI and CT. We've got high signal there in the geniculate ganglion, tympanic segment, and a bit of the meatal segment of the nerve. But that wouldn't necessarily mean a lot in a facial palsy unless there was evidence of expansion or erosion of the canal at that site, and you'd only really see that on a CT as well. So I think all intratemporal facial palsies, assess them with both modalities. And I expect you might have got a PET as well, but I don't know that would be worth very much.
So luckily for me, because like you mentioned, he's my next door neighbor, within the week or so after he was getting his MRI scan, he turned out to develop some ulcerations, painful ulcerations on the skin of that side of his face and his mucous membrane. And so clinically he was diagnosed as having herpes zoster, yes. Luckily. So the prognosis with him has been quite good. He's exactly a year now since his treatment. There's no sign of recurrence of being followed, and was in fact reconstructed with skin graft. So let's go on to case number 2.
See, it's interesting though. Why should a man with ear canal and perineural invasion get facial paralysis?
It's from the herpes zoster.
No. I'm talking about, we are suspecting tumor recurrence.
Of course.
Tumor recurrence, they are both remote. He had no bone invasion. I would be most surprised if that perineural invasion was due to cancer, in the absence of massive bone destruction.
You'd be a very brave man if you ignored it.
No, I at least know 3 cases where patients suddenly had cranial nerve paralysis without evidence in MRIs, repeated MRIs, thin slice technique CT scans, and where just the clinical suspicion said there must be something. Right. We went in, biopsied the nerve and adenocarcinoma, and we never found the primary. 3 cases.
Well, our concern here was that he did have the cancer of the ear canal. He did have, which is in the neighborhood of the facial nerve. Right. We'll all agree. And the second thing is he had perineural involvement, and so you can't be sure about how exactly the perineural involvement will manifest itself. And And so that the idea was that we were concerned that this was something related to the cancer and the perineural involvement. And but lucky enough, he's related more to his immune suppression and the herpes than to the tumor. So we're able to maintain his quality of life, as you suggested. This is a patient who's a 70-year-old woman with a 4-month history of rhinotalgia and serous-sanguinous drainage and a mild hearing loss in the involved ear. And here you can see the lesion itself around the external auditory meatus, and the entire external auditory meatus was filled with friable tissue so that the tympanic membrane could not be visualized. Now, in this case, the MRI, as you can see, is shows quite extensive tumor involvement. And here you can see further this appears to be involvement of the dura, and in this view, possibly involvement of the brain. So, Mr. Gleason, what do you think about this patient? The path report was, again, invasive squamous cell carcinoma, and here you have the radiographic findings. The physical findings did not show any lymphadenopathy or anything else more than what you saw, no facial nerve paresis. And so these are the imaging studies, and where would you go from here?
Well, she's got stage 4 disease, and her prognosis is desperate. I think there are some stage 4 tumours that you can cure, but in fact very few. And I think when you get that degree of dural infiltration, the chances of you actually resecting it completely are minimal. And at what cost? And so I would look at the patient very carefully. I would obviously respect their wishes, but I would be pushing that patient probably towards palliative care.
This patient's in good health, has a very good functional profile.
She'll be dead within the year.
70 years old, very fit, gets around, good exercise, tolerance, no history of any other, no comorbidities.
I personally don't like these tumours if they're infiltrating the brain or if they've got widespread dural infiltration. And that dural infiltration goes right onto the temporal lobe medially, and I'm quite sure I can't cut it out completely. It's right round to carotid artery. And I think that's incurable.
Professor Mann?
Well, I also think you pointed out patient has good quality of life, good general health, little discomfort from her disease, poor prognosis. I would go, and I would not do it in a palliative approach. I think we have new antibodies in our therapeutic armamentarium combined with chemotherapy or with radiotherapy. I would go for this, and I think she would have a realistic chance of surviving I think more than 2 years, 3 years, with a good quality of life when we try this new therapeutic protocols. Even they are not proven yet and highly experimental, but I think we have seen enough anecdotal evidence that this works. So I would go this way.
Professor Shah?
If you would permit me to show one slide of a very similar patient. Can you show me the second slide? In my early years, I was very enthusiastic that I can take out anything. And I did. No, go to the previous slide, not this. Thank you. This is somewhat similar to what you are showing, maybe a bit more. And the imaging studies showed very similar extent of bone destruction gene as you showed in your patient. You see the surgical defect in the
except for the temporal lobe.
Where we took the dura over the temporal lobe. That's a dural graft. And we cleared all gross disease. I was very happy that I had a good operation, put in a rectus free flap. She lived for 4 months, developed recurrent disease under the flap, and succumbed to her disease at 9 months. So I concur with the panelists. The patient you showed is not a surgical problem.
Now, how about, let's think about this same or similar patient, but without the dural involvement. What would your approach be at that point? Would that change your approach?
Yes, it probably would. I mean, the patients who do really badly are the ones where there's either brain involvement, dural involvement, or sometimes it goes right down the eustachian tube, and I've seen it coming out of the nasopharynx. So around the carotid artery is a bad sign. But if the dura is not involved, patients young, good, fit and healthy, they're the ones that I was getting those results in. And I would certainly go for the patient. I do an en-bloc resection, superficial lobe of the parotid, levels 2, level 3, because I'm there, and give them post-operative radiotherapy and pray.
Professor Booth, what about the idea of reconstruction in a case like complex lateral trunk bone?
Yeah, well, first I would like to stress that I don't know, well, it's just the dural infiltration which is the limiting factor in this case. It's, what do you say, it's the infiltration of the carotid artery and the extension towards the nasopharynx and the clivus. And I think this makes the case very difficult to be resected. Well, we have some good experience with our neurosurgeon to resect the dura and even to resect part of the temporal lobe as well. But if we can approach this case surgically, I think probably if we have to resect quite a bit of dura, we have to reconstruct it. And in this case, we can use the flap you showed, whether it's rectus abdominis or latissimus dorsi flap.
Yes.
I've seen these patients when we resected the dura and when we reconstructed and gave them post-op radiotherapy. They had intracranial metastasis within a year, or just enlarged dural spread. So for me, this was before we even discovered the local recurrence. They had on control MRIs. They had intracranial or intradural metastasis. So this was my limiting factor. So that's why I'm backing off more and more in this. It's not a technical point, you know.
I think, if the comment I made on the earlier panel about the large collaborative study of 1,500 patients, we put that data of those patients into multivariate analysis. And dural invasion was an independent parameter of prognosis adversely affecting survival. So I think dural invasion, yes, we can take it out and replace a patch of dura. You are absolutely right. They get leptomeningeal recurrence. They get local recurrence under the dura and on the brain. For temporal bone, at our institution, if you cannot clear the tumor lateral to the internal acoustic meatus, then we would not operate. So that's our limiting factor. Internal acoustic meatus, lateral lip. If that's clear, then you are fine. Go ahead and do it.
So here's another patient, 82-year-old patient complaining of progressive hearing loss in the right ear. She has severe hearing loss in the left ear. For many years she wears a hearing aid, and she's well, for exception of refractory anemia from myeloplastic syndrome. So the only abnormal physical exam was a pulsatile mass protruding from the middle ear. What next with this patient? What would you think about as far as your differential diagnosis? Professor Mon, what do you think?
Well, differential diagnosis of pulsatile mass in the ear, in the ear canal or behind the eardrum is many. Glomus tympanicum, meningioma, even only a blue drum, a small hemangioma, all sorts of. But in this patient, I saw, first thing I would like to get a CT scan of the temporal bone, and because MRIs for smaller lesions are of low diagnostic value. So first I would like to get a CT scan.
Well, we have an audiogram showed a severe central neural hearing loss.
Okay.
And imaging studies we have right here.
Okay. So in this situation, I would get an MRI in addition to this. and not only in MRI but also in MRI